Meningitis, by definition, is inflammation of the brain and the spinal cord. You have meninges in your brain and on the spinal cord, and sometimes infections are triggered. They can be viral infections. With your viral meningitis, for these patients who get diagnosed with that, their symptoms just run their course and they don't end up with any deficits. Whereas your bacterial meningitis patients, they can end up having long-term complications such as vision and hearing loss, and maybe sometimes even some trouble swallowing and paralysis. With your bacterial meningitis, it is very deadly, as if untreated, there is a very high mortality rate. Thinking of your health promotion, health maintenance aspects, the best defense against bacterial meningitis is going to be the meningococcal vaccines. Especially when you first go off to college, they started requiring that students who are going to live on campus in dorms get vaccinated with the meningococcal vaccine because of that high risk of bacterial meningitis being spread throughout the dorms. So, are symptoms for a patient who might have meningitis? One of the hallmark symptoms of bacterial meningitis, or I'm sorry, I should say of meningitis, is going to be that neck stiffness or nuchal rigidity. That patient can end up complaining of a fever because it is inflammation and infection. They can have photophobia with a very, very bad headache. They can also start to have some changes in level of consciousness. They also have a risk of seizures, and the seizures would be due to increased intracranial pressure. So that is a complication of meningitis, increased intracranial pressure. And there are two unique assessment findings specific for meningitis. First, we have the Kernig sign. A positive Kernig sign is where that patient is lying supine and you instruct them to lift their leg and then bend their knee and then straighten out that knee. That extension of the leg from a flexed knee position ends up causing back pain. And that is a positive Kernig sign. So back pain with extension of the leg from a flexed knee, that is a positive Kernig sign. So think Kernig's knee flex. Our positive Brzezinski sign is where that patient is going to complain of neck pain. Going to complain of involuntary flexion of the hips and knees when they bend their neck forward. So once again, the patient is laying supine and you're going to instruct them to put their chin to chest. And that action, that flexion of the neck causes the hips and knees to involuntarily flex up. And that is a positive Brzezinski sign. Think positive Brzezinski's. Brzezinski's means we're bending the neck. When that patient comes in with symptoms, we need to figure out what type of meningitis, if they even have it. Before we do the diagnostic of a lumbar puncture to confirm meningitis, we need to send that patient to CT to get a CT of the head and neck just to ensure that there hasn't been a complication of herniation, brainstem herniation occurring due to the inflammation and fluid shift. So that patient will need to undergo a lumbar puncture to confirm meningitis. This is a very infectious disease. So before we even start doing treatment or diagnostic studying on this patient, we need to put that patient on droplet precautions. The provider is going to do the lumbar puncture while we are at the bedside assisting as necessary. And the provider is going to be collecting some cerebral spinal fluid in a little tube. Now, when the cerebral spinal fluid comes out, we can get a kind of preliminary diagnosis by what the color or consistency of that spinal fluid looks like to give us indication if it's viral or bacterial. So if the fluid is clear, if our cerebral spinal fluid is clear, that is consistent with viral meningitis, whereas if it comes out cloudy, that cerebral spinal fluid is consistent with bacterial meningitis. But of course, we're going to send that fluid off for cultures to get a final confirmation, but we can kind of have an indication of what type of meningitis that patient might have. Now, before we decide to take them to treat this patient, we can go ahead and preliminarily start them on wide or broad spectrum antibiotics. We can either start them on IV vancomycin or IV ceftriaxone until we get cultures back. So that'll be for about 24, probably max of 48 hours. Once we get confirmation that that patient does not have bacterial meningitis, then we can take them off of antibiotics, but we keep them on antibiotics until we confirm if we have bacterial or viral meningitis or not. And as I said, droplet precautions. So making sure that we wear a mask when we go in the room, gown and gloves when we're doing patient care, only because droplets can fly off, and a face shield will be beneficial as well. Any family members who come to visit, same thing, need to understand about the precautions as well. That headache that that patient can have, we can give them Tylenol for to help with that pain. We can also do the Tylenol or ibuprofen for the fever that they could be experiencing as well. We want to make sure we keep this patient hydrated. So we're going to give IV fluids. We want to keep them in a calm, quiet, cool room with not as much distractions. As bacterial or meningitis, I should say, as a whole forms or develops, that patient could start to hallucinate. And if so, we can start, with least invasive and have family at the bedside that can help be that familiar face for that patient and decrease hallucinations. We also have to be careful when we administer certain sedating medications like codeine, because even though codeine can help for pain, like for that headache, it could mask some changes in level of consciousness that could indicate that patient is developing increased intracranial pressure. For that patient with meningitis, we are going to implement our increased intracranial pressure precautions, our ICPSS, to prevent the increase in pressure. We want to make sure that we don't do any suctioning. We want to make sure this patient is not straining or anything. Let's keep that head of the bed at minimum 30. If necessary, we can immobilize that neck with a C-collar if necessary to keep them from flexing their neck. And then we want to make sure that, once again, we have seizure precautions just in case. If they do start to develop increased intracranial pressure, we can administer phenytoin, our anti-seizure drug, and then we can give IV mannitol to bring that blood pressure down. All right. So for our patients with meningitis, the big thing is going to be safety, making sure we do droplet precautions. We get our cultures, our cerebrospinal fluid cultures, so we can send them off to see if it's viral or bacterial. We give them antibiotics until we can confirm that it's viral. So let's do the one practice question. Which interventions would the nurse implement in providing care for a client with meningitis who has a fever? Select all that apply. So as always, think about when you read the question, meningitis and fever, we're trying to do things to probably lower the fever. So your first option, reduce fever with use of acetaminophen. That is correct. We know we can do acetaminophen, or we can also do ibuprofen as well. Reduce body temperature rapidly to provide relief. We never want to bring that body temp down fast. It's going to be a slow drop in the body temp as we cool them down. Think about all the way back in week 2 when we were talking our heat-related emergencies for heat stroke and heat exhaustion. We said that we slowly cool the body down. Use a cooling blanket on the patient to reduce the fever. That is appropriate. Encourage shivering in the patient to help reduce the fever. We're not going to encourage shivering. Sometimes patients have those rigors or those chills. It's just an involuntary body reaction. So we're not going to say shiver to lower your body temp down. And then we can lower the body temp by using tepid water sponges. And tepid water means like cool room temperature water. If necessary, we could also do ice packs for this patient. Remember, we can cool the body down with ice packs on the back of the neck, underneath the armpits and in the groin as well if we need to. All right. So patients with meningitis, we need to cool that body temp down as we treat them.